Welcome, everyone, and it's really my honor to be with you, colleagues in respiratory therapy. I'm here with my colleague, Alyssa Dittner, also respiratory therapist, to help understand and update you with bronchiectasis and NTM lung disease, non-tuberculous mycobacterial lung disease. This is an exciting time, and I hope over this next 40 or 50 minutes, we'll be able to share some information. We will have a Q&A session at the end of this to try to dive a little bit deeper into what we think might be helpful information for you and in your practice regarding bronchiectasis. So again, it's great to be with you, and I look forward to the Q&A at the end of the session. I do a lot of work in clinical studies, but all the support goes to my employer, Mayo Clinic, here in Rochester, Minnesota. So again, clinical disclosures, but nothing that is pertinent to this talk. Over this next 40 or 50 minutes, I want to share some information with you regarding just a little bit of information about the pathophysiology, the epidemiology, and the signs of symptoms of bronchiectasis, what the diagnosis and treatment options are. I think it's worth emphasizing that bronchiectasis is not a COPD or asthma, and we'll talk a little bit more about that. We're going to identify some strategies for you to be mindful of for patient education and support, not only for you and your colleagues, but patients and their caregivers, and some associated information about increasing awareness through the program of World Bronchiectasis Day, and hopefully then open up a discussion with some insight during the Q&A period. So let's first turn to the pathophysiology, epidemiology, and signs and symptoms of bronchiectasis. And there are really four main parts of bronchiectasis that I want to emphasize. And in the current construct, as we understand it, infection, chronic airway infections is a common occurrence. Inflammation, that's usually neutrophilic. There is a group, about 1 in 5, about 20%, that has an eosinophilic component, but inflammation, and I'm going to come back to this, is a very important component of what we understand about bronchiectasis these days. There's epithelial cell dysfunction and impaired mucociliary clearance. Vis-a-vis, it's really important for you and in your practice to focus on airway clearance, and we're going to spend some time specifically about that. And that over a period of time, if there is progression, it leads to bronchial dilatation, which is really the hallmark of bronchiectasis. It's often associated with bronchial wall thickening and mucus plugging, all of which we'll address in a little bit more detail. I think it's sometimes helpful to look at the etymology of bronchiectasis, which is the bronchus, and ectasis is a stretching or a dilation. So that's where we get, in that these four pillars of bronchiectasis really result in a cycle. And this cartoon is taken from a recent New England Journal review of bronchiectasis by Dr. Ann O'Donnell from Georgetown. When I think about bronchiectasis, we used to talk about this cycling, but now we think about it as in the context of a vortex. And so the figure on the right really highlights that these are all interconnected and interrelated plays. That is the infection, the inflammation, the epithelial dysfunction, abnormal mucociliary clearance, and then the structural lung disease. And I like to think about this vortex almost, it looks like a hurricane, where we have this vicious vortex, and sometimes it spins faster or slower, sometimes in clockwise, sometimes counterclockwise fashion. Point is that these are all interrelated components, and we're going to address each one of those. It's important also to realize that bronchiectasis is increasing insofar as its prevalence and incidence. And the top cartoon on the right looks at over the past 10, 20 years that increase is about 8% per year. Some of that is the actual increase in disease, but likely also related to it's been increasingly recognized. It's estimated that at least 500,000 adults have bronchiectasis in the U.S. And in our experience in North America and the U.S., it's more common in women than men, which isn't necessarily the case in other parts of the world. The prevalence increases as we get older, and the lower right-hand cartoon highlights this nicely. And I think that that's something to be mindful of, that this is for the most part, a disease of aging. And so if you look at Medicare data, for example, in those individuals 65 years or older, the estimated rate is about 562 per 100,000. And this was data from just over 10 years ago, so it's likely higher than that. And so we can kind of get an idea, 60 and older, 3 to 500 per 100,000, under 50, maybe 40 to 50. So as we see an aging population, we can expect that we're going to see more bronchiectasis in your practices, whether it's in the clinic or in the hospital. Not surprisingly, the cost of taking care of patients with bronchiectasis also increases. As the severity of bronchiectasis increases, these costs increase substantially. And on the top right-hand cartoon is a representation with a bar graph of just how much that cost will increase. And the lower cartoon really gives you an idea of what that cost is distributed across. That is the use of inhalers, inhaled antibiotics, which I'm going to come back to, exacerbations, and of course, admissions to the hospital. We understand that when there are certain pathogens, in particular, Pseudomonas is present in the setting of bronchiectasis, that further increases the cost of taking care of these patients with a substantial burden on the healthcare utilization. When I think about what are those associated causes that go along with bronchiectasis, there's a long list. I would share with you at the bottom of this that idiopathic remains the most common cause of bronchiectasis in most series, not all. And that doesn't mean that there's not an underlying cause. It just indicates that we're probably not insightful enough or have the science or data to understand that. What we do know is that there are some areas that can be associated. So during those times that you're seeing your patients, these are things that you want to think about. Is there an autoimmune disorder, in particular rheumatoid arthritis or inflammatory bowel disease like Crohn's or ulcerative colitis? Does the patient have unchecked GERD or an aspiration or even a foreign body? Commonly, post-pneumonia bronchiectasis can occur, and there are specific associated infections, in particular NTM or non-tuberculous mycobacteria, that are associated with bronchiectasis. And that's to say that just about all patients with NTM lung disease have bronchiectasis, but only about a third of bronchiectasis patients get NTM in our experience in the US and North America. Do patients have immune deficiencies, hypogammaglobulinemia or decreased immunoglobulins? Are there other immunodeficiencies which can contribute to infection and then subsequent bronchiectasis? And then there's other genetic abnormalities. We understand in cystic fibrosis, for example, that we're increasingly diagnosing adults with cystic fibrosis later in life, in their third, fourth, fifth, and even sixth and seventh decades. Primary ciliary dyskinesia, a genetic disorder which affects that mucociliary clearance in a wide range of possibilities. There's overlap in the setting of COPD or asthma. Doesn't mean it's one or the other. And then there's a hypersensitivity of allergic bronchopulmonary aspergillosis, or ABPA, that oftentimes is associated in particular with centrally focused bronchiectasis. The symptoms that are most commonly associated with bronchiectasis are nonspecific. That is to say, cough with or without sputum, generally the case. Fatigue, very common. Shortness of breath, chest pain, and intermittent fever. And I think it's important for us when we're in our practice, especially with respiratory therapy, and this is a theme I'm going to emphasize a little bit more, is when should you suspect bronchiectasis in your patients? That is, the person that has a chronic cough with sputum production that's not responding to therapy, or is having frequent respiratory infections and is getting either admitted to the hospital or receiving oral antibiotics. So when we think about diagnosis and treatment options, where does that bring us to? In most instances, this is a diagnosis that's made by CT scan, oftentimes high resolution chest CT scan, and the hallmark again is a dilation of the bronchial tubes. We can quantitate that with a bronchoarterial ratio of more than 1 to 1.5. And oftentimes, if there's a dilation of the bronchial tube and adjacent to that is a bronchial artery, it is sometimes called a signet ring, a ring with then a jewel on top and the jewel representing the artery. Lack of bronchial tapering with the dilation that occurs and that the bronchi become visible up to within 1 centimeter of the pleura. Oftentimes associated is this accumulation of mucus with mucus plugging, sometimes described as tree and bud infiltrates. You'll see that on the radiology forms, or bronchial wall thickening, which is a nonspecific, oftentimes inflammatory change within the bronchial wall itself. I wanted to show just a couple of different images, and these are 2 different patients, and just to emphasize that there's a spectrum of disease, and it does vary. Some individuals have very mild disease with minimal symptoms, as is represented in patient 1 on our left side of the panel. There's some mild bronchiectasis, primarily involving the right lung field, and not so much on the left. And then the patient 2 on the right panel has more diffuse bronchiectasis with generalized findings, including bronchial wall thickening and more advanced. So the point only is that we have to be mindful that not everyone has the same amount of bronchiectasis, and we have to accommodate our diagnostic and therapeutic plan to accommodate these variations. And our goal is to really prevent progression. I oftentimes share with patients in particular that this is a scarring or a dilation of the bronchial tubes. And I use the example of if we cut our finger with a knife and it heals up, we have a scar on our finger, and that scar will never go away. And that's not dissimilar to what we see in bronchiectasis. That is, once it's there in adults, we think that that's there permanently. So our goal isn't to make the bronchiectasis go away. Our goal is really to prevent that from getting worse. And we'll talk about how we best think about that. In fact, there was a group of us that put together a review of clinically important bronchiectasis, and this was done primarily for research purposes, but really is quite applicable for us in our practices about clinical work as well. That is, we start out with a clinical suspicion for bronchiectasis, cough, frequent infections, sputum production, and then look at the CT scan. And if it's abnormal in the context of these findings, then we call clinically significant bronchiectasis. Sometimes patients may have a CT scan done for other reasons. They go into an ER, they have chest symptoms, they get a CTA, the CTA comes back, no evidence of pulmonary embolism, but there's a very small amount of bronchiectasis, but they really don't have clinical symptoms or a syndrome to go along with that. And that's really not the person that we want to focus our attention on, but somebody that has more symptoms. I wanted, as previously mentioned, to emphasize that bronchiectasis in itself does not equal COPD. Does not mean that they're not related, but oftentimes patients have a misdiagnosis and been told they had COPD when they have bronchiectasis, and that oftentimes results in a delay in diagnosis. In fact, the way I think about this is we know that we have patients with COPD, we know we have patients with asthma, and we know we have patients with bronchiectasis. They're not all mutually exclusive, and they're oftentimes with an overlap, and I think that this Venn diagram will capture just the nature of this, so that it's not uncommon for us in our practice, whether again in the clinic or the hospital, to have patients with asthma or COPD and bronchiectasis. And we need to take care of each one of those conditions based on the specific diagnosis. Let me share with you a quick case, and that might highlight some of the aspects of treatment that I think are going to be important to be mindful of. This is a 78-year-old female that was seen previous smoker, came in with cough, sputum, and dyspnea. Had carried a diagnosis for more than 5 years, had some autoimmune hepatitis, portal hypertension, some GERD. BMI was low at 17, so had lost some weight, had a pectus, but no other acute findings on exam. Blood work, CBC, other than the thrombocytopenia, was unremarkable, including electrolytes. And this patient had more than 4 exacerbations in the past year. Her immunoglobulins were markedly reduced, the IgM, IgA, and the IgG to a lesser extent. Had normal alpha-1 antitrypsin, normal IgE, which is used as a screen for ABPA, or the allergic bronchopulmonary aspergillosis, and had a normal sweat chloride. Sputum had more oxala in it and received a course of augmentin or amoxicillin clavulanic acid for that. This is her pulmonary function test. Many of you are familiar with this. The flow volume loop, obstructive morphology with a mild to moderate reduction based on Z-score in FEV1, preserved diffusing capacity, and preserved oxygen saturations at rest and with exercise, and in part may have been why she had the misdiagnosis of COPD. Her chest x-ray had bronchiectasis in the mid to lower lung fields, the left more so than the right. And on CT scan, we saw this better represented with not only bronchiectasis involving both lung fields, left greater than right, but in the mid and lower zone predominant, associated with mucus plugging. And again, incorrect and a delay in diagnosis. With these findings, she was started on aggressive airway clearance, was treated for GERD, some upper airway disease, and had IVIG replacement. And as a result of this, her exacerbations that had been more than 4 in the past year had been then resolved, and going on 18 months, completely resolved. So the point is that if we identify what those contributing factors are, and we are able to institute effective airway clearance, this is a manageable condition. The x-ray, the CT scan will not be normal, but our goal is to shoot for abnormal but stable. So some of the things I'd like you to kind of take away from this as you think about this in your practice is to know your patient, who and when to ask about, is bronchiectasis present, to avoid this delay in diagnosis, which is all too common in this cohort of patients. And just to emphasize, as previously mentioned, those individuals that have a chronic productive cough, somebody that's receiving antibiotics, either as an outpatient or an inpatient, we generally say 2 or more per year for respiratory infections. If we collect a sputum and we see Pseudomonas or NTM present, the most common is MAC or Mycobacterium avium complex in sputum, that should be an indicator to be concerned whether or not bronchiectasis is present. Do patients have refractory symptoms even though they've been given a diagnosis of asthma, COPD, or both? Do they have any episodes of hemoptysis, which oftentimes is an indicator? And then do they have other symptoms that are not explained with fatigue and weight loss? And it's in those situations when you see these patients, ask ourselves, have they had a chest CT scan? And if not, that would be an appropriate next step, because that would take us down a different path on the algorithm and help with their therapeutic plan. So when we think about the diagnostic issues, we think about taking a history, we look for those associated causes, even though we understand many are idiopathic. That starts with our history and our exam. I would have a low threshold for a CT scan, most times a high resolution. Sputum cultures can be very helpful, including bacterial, mycobacterial or AFB, or fungal cultures. Pulmonary function tests, sometimes there's restrictive changes, sometimes obstructive, sometimes a mixed bag. And then laboratory tests to try to identify, are there other contributing factors? And that usually involves a CBC with a differential, immunoglobulin levels, including the IgE for ABPA evaluation. And then when appropriate, thinking about genetics and sweat chlorides, looking for cystic fibrosis and abnormal ciliary function, or PCD diagnosis. Which brings us back to this vicious vortex of these interrelationships. And I want to start to think about each one of these components insofar as the treatment plan for bronchiectasis. Let's first talk a little bit about the epithelial dysfunction and impaired mucociliary clearance that generally then really focuses our attention on what can we do with airway clearance, and sometimes using mucus thinning medications or mucolytics. In most instances here in the US and North America, the most common would be nebulized hypertonic saline, either 3% or 7%. In cystic fibrosis practices, especially in kids, they start out right at 7%. Sometimes that's a little bit too strong and will increase intolerance or respiratory symptoms. And adults with non-cystic fibrosis bronchiectasis oftentimes will tolerate 3%, but not 7%. Some patients in some areas of the world will use N-acetylcysteine or NAC. There's limited data to support that, but you'll see patients that have tried that. Mannitol, which has been used as a mucolytic, is not recommended, and certainly Dornase alpha is not recommended for non-cystic fibrosis, even though it's used very frequently in CF. Guaifenesin is another one of the mucociliary mucolytics that sometimes is used, and again, the response is variable. With that, I'm going to shift over to my colleague, Alyssa Dittner, a respiratory therapist, and have her share with you, as a respiratory therapist, some of the aspects of airway clearance that we think are important for you to recognize and to incorporate into your practice. Alyssa.
All right, thank you, Dr. Axman. So like you said, I just want to take a moment to highlight our vital role as respiratory therapists and really emphasize the importance of airway clearance, especially when it comes to this subset of patients. As a respiratory therapist, we do play a critical part in educating patients about how regular and consistent airway clearance can significantly improve their lung health, reduce infections, as well as enhance their quality of life. Symptoms such as excessive coughing, sputum production, and dyspnea significantly impact a person's quality of life. And like Dr. Axman had mentioned, these symptoms are commonly associated with bronchiectasis, unfortunately leaving many patients to experience a lot of social isolation due to their concern about how other people will perceive them as well. So airway clearance is a fundamental aspect of managing bronchiectasis and interfering with this vicious cycle. The impaired ability to clear mucus from the dilated bronchi can cause secretions to accumulate in the airways and can cause the lungs to become more susceptible to chronic bacterial infections, causing further progression and then more symptoms. For this reason, all patients should utilize some form of airway clearance therapy and should adjust their treatment plan based on their own individual needs. So there are numerous positive effects associated with regular airway clearance, including an increase in sputum volume. So by loosening up this mucus and mobilizing it, this helps the person to be able to clear their airways. They're clearer, they help to reduce the mucus from building up, and again, decrease infection risk. They also help to reduce peripheral airway obstruction. So by clearing the mucus from the smaller peripheral airways, this can prevent the blockage, improve the airflow, and then enhance the overall lung function. With consistent mucus removal, it can help to lower inflammatory cells in the sputum, and then it actually improves exercise capacity. So when mucus is effectively cleared, patients often experience less breathlessness and less fatigue with their daily activities, and that's going to help to boost their ability to stay active and to maintain more of a daily routine. And then, of course, all of these benefits collectively contribute to improvement in a person's overall well-being and quality of life. So it reduces the impact of cough on the quality of life. When they experience these fewer symptoms, like coughing and short of breath, when they experience fewer symptoms, then people are going to be able to enjoy increased ability to participate in social work and recreational activities. So looking at breathing techniques for airway clearance, research shows mixed results about which technique is best, largely because bronchiectasis patients vary widely in their airway structure, their mucus properties, and then their respiratory strength. That's why, again, airway clearance is a personalized prescription. What works best is the method that a patient can be consistent with and perform it over a long period of time. So the main goal of using these breathing techniques listed is to promote effective mucus mobilization and clearance by using controlled or active exhalation with an open glottis, often employing a huff to maintain that airway patency. Keeping the glottis open reduces the effects and the effort. It reduces that effort required for a cough. It helps to prevent that forceful, jerky cough that often causes people a lot of irritation and fatigue. But instead, it actually helps to encourage more of a gentle and sustained exhalation, making mucus clearance more comfortable and efficient. An open glottis allows that air to flow smoothly and steadily through the airways, helping to detach and move that mucus from the airway walls. And it also prevents airway collapse or atelectasis. So when it helps to do that, especially in the smaller or weakened airways, ensuring mucus can move upwards and outwards more easily rather than getting stuck. So with all of this being said, it really comes down to good coaching. So good coaching, patient cooperation, and tolerance, those are going to be essential for success with using these different techniques. The most widely used techniques are going to be your active cycle breathing. So that takes a bunch of different breathing techniques and puts them into one. It helps to combine that controlled breathing, open, and create that thoracic expansion. And it helps to force, again, through that open glottis to help move mucus. Huff cough, which is a really great tool. Again, we talked about how when we have this controlled breathing, this open glottis, it makes it so people don't use up all of that energy, and it helps things to flow a lot easier. Then we have our autogenic drainage, which involves inhaling at various different volumes and adjusting exhalation force to mobilize those secretions as well. These are all hyperlinked, so when we give you access to this PowerPoint, I would suggest looking up these and learning what the process is to accomplish each one of these. Then we have something called ELTGOL, which is your expiratory lateral turn with an open glottis. And this one uses the position, a lateral position, using that open glottis to allow for slow and sustained exhalation using gravity. All of these are really great tools to help a patient mobilize the secretions. There are various techniques for unblocking any sort of obstruction or for clearing mucus, which is going to require different physiological mechanics. So you could have increase the expiratory flows, oscillating airflows, and then just enhancing what the lung volumes is that the patient is using. So a lot of different things go into helping a patient be able to mobilize that mucus. So for example, your positive expiratory pressure or your PEP device, the PEP device allows for normal inhalation, and then it provides that resistance, the expiratory resistance, and then during that exhalation, and it helps to splint open the diameter of the airways to help create more space so that they can mobilize that mucus. Then we have our OPEP device, or oscillatory positive expiratory pressure. And with this type of device, you also have normal inhalation, and then it provides that resistance while creating a gentle vibration so we can help to loosen and shear off that mucus from those lung walls. Then another option, which is going to usually require assistance from somebody, but it's more of your hands-on technique, your manual chest physiotherapy. So your hands-on technique, running up the chest, the sides, and the back. And then our postural drainage. So strategically positioning patients to use gravity to drain mucus from the lungs. Now, this one is a really, really good tool for patients to be able to use at home, because while they're doing pairing, like you can even pair different airway clearance methods together, but they can be using the assistance of gravity to drain that mucus while also being able to gently vibrate and loosen up that mucus as well. And then we have our high frequency chest wall oscillating device, and that one delivers the vibration to help loosen up and remove that mucus, tear it off those walls. And this is done in two different ways. This can be done with an inflatable vest, which applies pressure, releases pressure, and has different variations. And that one's going to be powered by a compressor. And then we have our vest that contains oscillating discs, and that one's going to be powered by batteries. But educating patients about what options are available and the process of which these different techniques works is going to help enhance the compliance. So with airway clearance, what are the clinical outcomes? So what does the science say? There was several studies that evaluated patient reports of improved health-related quality of life scores when using airway clearance methods. So our health-related quality of life score measures things like symptom severity, a person's activity level. It also helps to measure how a disease impacts a person socially, mentally, and just overall their health and well-being. So they noticed that there was significant improvement in the quality of life scores. And that was with the evaluations, they found improvements in the physical, physiological, and the social, all by using airway clearance techniques. Through the meta-analysis, they also showed a reduction in the FRC, so your functional residual capacity. When using different airway clearance devices, the amount of trapped air decreased by around 19 to 30%, and that was depending on what type of device and technique that they use. But overall, using airway clearance methods, patients reported a reduction in symptoms compared to those who did not do any sort of treatment like that. So the benefits, when we look at specifically what are the benefits of using their high frequency chest wall oscillation vest, is decrease in hospitalizations, decrease in length of stay by 33%. And they looked at this data 12 months prior and then 12 months with them using this consistency of using airway clearance devices and using the vest. When they looked at that, they noticed that there was a decrease in hospitalizations, hospital visits, from 2.4 visits the first 12 months to 1.8 visits on the second set of 12 months. And then also a significant impact in what their antibiotic needs were. So fewer antibiotics were needed when they were using this type of airway clearance. They used 9% less of the oral antibiotics and then 47% less of IV antibiotics. So again, the best type of airway clearance for a person really depends on their specific airway structure, their mucus properties, and what is their respiratory strength. So it's important to help them choose a method that seamlessly fits into their daily routine, allowing them to maintain consistency and allowing them to really feel the full benefits of using these different techniques. Regular airway clearance isn't just a routine, it's a practical way. It's a way that they can help to transform their quality of life. And back to you.
All right. Thank you, Alyssa. That was absolutely spectacular. And just a couple of points to emphasize, as Alyssa has really nicely outlined for us in our practices, again, in the hospital or in the best airway clearance is a question very commonly encountered by all of you and us for sure. And it's the one that the patient can do. And I think I had seen some comments in the chat area. It does require sitting down and with intensive amounts of education. So it has to be, as Alyssa said, individualized and personalized, and the best airway clearance is the one that the patient can do. And we think that airway clearance improves mucociliary clearance, decreases exacerbations. And I should have clarified that earlier, that an exacerbation is a flare, and it's usually defined as 2 or more symptoms for more than 24 hours and generally requiring an intervention. Most times involves antibiotics. As this impacts patients' quality of life, and in particular cough, you can just imagine that these patients cough regularly and all the time. And in our post-COVID world, it has a huge impact on patients' quality of life, social isolation. So whatever we can do to try to minimize that, to get patients to engage with their families, with their communities, it will really improve mental health, which is a big issue in this regard as well. So I want to turn, though, to other aspects of this vicious vortex, if you will, and look at the infection, which is oftentimes associated with these exacerbations. We like to collect sputum. It's very helpful for bacteria, fungus, and mycobacteria. So I would encourage you in your practices, whether outpatient or inpatient, is to collect sputum, and often, and then to understand antibiotic selection when we need to, especially for those patients that are having frequent chest infections. Inhaled antibiotics are often used as we start having more frequent exacerbations in select patients, and that's defined somewhere between 2 and 3 infections per year. And that the best evidence that we have for use of inhaled antibiotics is with inhaled aminoglycosides, or tobramycin, or Toby, that many of you are familiar with. We sometimes use gentamicin as well, or more recently we've gone, and it's been the European experience, to use colistin. And it's interesting whether to use those on and off in a traditional cycling for Toby, or in colistin, which we have a tendency to use that continuously and not in the on and off cycles that has previously been done historically. Let's turn in this vicious vortex to the next component, and that's inflammation, which we've come to increasingly appreciate as a critical part of the driver behind bronchiectasis. I would just share with you that inhaled corticosteroids are very commonly used. There's not data to support that, and as a general rule of thumb, we do not use ICS, or inhaled corticosteroids, for bronchiectasis. Having said that, if there's an underlying diagnosis of asthma or COPD that requires that, not a problem. But we think that ICS will increase the risk of infection, including bacteria as well as NTM. One caveat that I would share with you is the use of macrolides, that is azithromycin or a Z-Pak, or erythromycin as chronic long-term immunomodulatory purposes. That is, it decreases inflammation more than as an antimicrobial effect, and has been shown to be effective in select groups of non-CF bronchiectasis patients, that is, non-cystic fibrosis bronchiectasis patients, in decreasing exacerbations, especially those who are having frequent occurrences. And then I really need to share with you as well, there's a lot of new areas being developed, and there was just published, there's a new anti-inflammatory agent called brensocatib. It's an oral, potent, reversible inhibitor of neutrophil, this inflammatory component of the neutrophil called dipeptidyl peptidase, or DPP1, and it inhibits other neutrophil serine proteases. But it's been shown to not only decrease exacerbations or flares in a phase 3 study just published in New England Journal as referenced here, but it also is, in some groups, actually improves the decline in lung function associated with bronchiectasis, which is really a game changer for us. And there's more to be shared about that. This medicine is not FDA approved yet. It's up for review later this summer, and there are several companies working in this space with DPP1 inhibitors, but something I think you'll see more of certainly in the next few months. As far as other areas, when we think about this inflammation, again, a neutrophilic or an eosinophilic inflammation that goes along with asthma. Sometimes you'll hear people talk about Th2 response. That's just the type of eosinic inflammation that goes along with asthma. There's lots of different studies that are ongoing, and this just is a list, not to specifically mention any one in particular, but just to understand that with this vicious vortex, not only with inflammation, neutrophilic and eosinophilic, but with areas of impaired mucociliary clearance and education. There's lots of studies, and this list was taken from a recent reference, just taken off clinicaltrials.gov. So this is a very exciting time and space with lots of activity ongoing. So what can we do, you and I, for patient education and support to help us in this area? The Bronchiectasis and NTM Association is developing a care center network with care center delivery with a multifaceted approach to support you, providers, patients, caregivers, and raise awareness and education at the national level. The goal is to have between 100 and 150 centers. There have been 33 thus far been qualified as centers of excellence, but we're looking to have this spread throughout the country. We encourage you, if you're seeing bronchiectasis patients and your providers that you're working with are interested, please reach out to the Bronchiectasis and NTM Association. There'll be links at the end of this talk, and we would be very happy to accommodate you. There's lots of resources to help you develop into a specialized center with advocacy, support, education to go along with this. Some of what's available includes durable materials, hard copy that's downloadable. There are podcasts, newsletters, there are support groups, and NTM 360 Social. So lots of activities. It's supported by many of the professional societies globally. And as a part of this global awareness, which is really part of the secret sauce of some of the improvement here, we now have 25 global partners, if you will, increasing recognition and awareness of bronchiectasis. This is a great website, and it really is a shared way that we can walk together. There are oftentimes other resources that you might find helpful for your patients that would be something you can use in your practices. As just one example of that, there are some durable materials, basics of bronchiectasis, research and clinical trials in the treatment of bronchiectasis in lots of different languages, not only English, but Japanese, Arabic, German, Spanish, Portuguese, Italian, French, and then Chinese, so that if you are interacting in your practice with individuals that need some materials in other languages, these are available in public domain, and I would highly encourage you to tap into these resources. This is, of course, all possible with some of our industry partners and collaborators. And with that, I, again, will thank you for your time. And I think we'll have time for a few questions to maybe highlight some of your concerns or questions that you may have. Thank you very much for your time today.